Good afternoon, everyone, and thank you for joining me in this session titled EMRs to Optimize Patient Care in a COVID World at the CPC QualiCare Virtual Open Day. I'm very conscious that this is right at the end of the day, so I hope to bring my A game and to ensure that the session is both informative and interesting to you. We all have a sense of the tremendous value in terms of cost, quality and access that digitized health can offer. However, in South Africa, just as in other parts of the world, moving to a digitized health paradigm requires major behavioral change simultaneously across tens of thousands of healthcare professionals and in fact millions of patients. Except for in a few niche cases, very little change has occurred in the absence of coercion. And even the cases of where healthcare professionals have been coerced into digitizing, like in the US, the realized results are not a fraction of what could be possible. So does this mean that the promise of digitization will elude our healthcare industry for still a few years to come? We don't believe so. Our experience over the last 12 years, where we've actively, albeit quietly, worked on engaging with healthcare professionals to use different forms of EMRs, indicates that a breakout point has been reached. There's clearly still a long way to go, but our experience over the last year shows that we've reached a milestone. While COVID-2019 has certainly played an important role in this shift towards using EMRs and telehealth, there is another key factor, and this is that it needs to start with an appreciation of the minute by minute, the in the weeds of what happens in a day of a healthcare professional. Only then will EMRs begin to make sense for healthcare professionals and therefore sustainably adopted. We like to think of adoption using the following model, developed by Professor B.J. Fogg of Stanford University. His most famous moment is having designed the like button for Facebook. And really what his simple model illustrates is that there are three things that need to be at play for sustainable behavior to take place. You need to be motivated to do something, that's the y-axis. You need to be able to do it, or it needs to be easy for you to do it, the x-axis. And then there needs to be a trigger that will push you above that orange line into the sustainable behavior model. If you're below the line, the trigger will fail. In other words, not a sufficient combination of motivation and ability or ease. But if the combination of motivation and ability is above the orange line, then you get action based on a trigger that you supply in that situation. So you also see that the curve is asymptotic. In other words, it never touches the axes. As an example, you could motivate me with R1 billion to jump unaided from the ground floor onto the roof of my house. I would be highly motivated to do that for R1 billion. But the ability to do so is just impossible unless I'm Spider-Man. And so you could make it R1 trillion and still I would not cross that orange line right up against that motivation y-axis with very little ability to do it. The great thing is this can be applied in all forms. One could argue that for a diabetic patient to adapt a new lifestyle, one has to give the patient sufficient motivation, and ideally it should be intrinsic motivation. You need to make it easy for the person in terms of maybe providing a diet, providing the right medications that gets delivered to his or her doorstep, an exercise program. And the trigger in this case could be that very powerful conversation that you as a doctor has with a patient. And hopefully that patient will move over the orange line and action will take place. Similarly with EMRs and the adoption of doctors with EMRs, the same curve applies. And so here we have what I believe is the default situation, that gray area really representing the population of GPs, if you like. You will see that a few have already by themselves cut across the orange line. These are known as the early adopters. They probably should have been engineers. They love tech and so they do it with intrinsic motivation, despite the ability or the ease not being very good. But the majority of doctors sit underneath the curve because either there's not enough existing motivation to do it, or quite frankly, the EMRs to date have just not made it easy for doctors to adopt EMRs. And so you get inaction, except for those early adopters. And as I mentioned, there's potentially no clear, tangible benefit to adopt. The EMRs of the day, if anything, add additional load from a cognitive perspective at that moment of care with the patient, with all the clicks and the pull down menus and so on and so forth. And by doing so, there's a loss of connection with the patient at the moment of care. And lastly, these tend to be ad hoc processes into existing practice processes, not necessarily for every practice, maybe for a specific scheme, or maybe only under certain conditions, and therefore it doesn't fit within a regular pattern inside the practice. And so the adoption is typically not great. What we've seen, the traditional approach, is to increase the motivation, and so that populace of doctors moves up, and one gets a little bit more adoption. This could be through the form of incentives or in sometimes penalties, legislation like the meaningful use in the US, or otherwise conditions of employment if you are working for a national healthcare system, for example. The result, however, is a little bit underwhelming. It's typically very costly with mediocre success, high stress for healthcare professionals, and this usage is under duress, and thus sustainable habits are not formed to use this EMR. And so if the motivational factors disappear, the adoption declines and that area moves back down to its original position pretty much. And lastly, and interestingly, there's very good documentation to say that in fact there's been reduced patient care capacity because of the additional work that doctors need to do to document the patient encounter through a typical EMR. So not a very good outcome. And of course, COVID has introduced an interesting factor that we've seen not just worldwide, but in our country too. It in itself has been an extrinsic motivator to adopt EMRs and telehealth. Why? Well, it's at least one way to continue to care for patients. If the patient is suspected of COVID, or the doctor, at least, for example, through telehealth and documenting through an EMR, the patient care can continue to some extent. And secondly, another motivator is to at least mitigate some revenue loss that the practice endures, as we saw last year during the heat of COVID. And so this has introduced some further external motivators, which has brought on a further adoption, although we don't think necessarily sustainable over time. So at Healthbridge, after 12 years of tussling with this EMR concept, spending a lot of money on investment, refining our thoughts and our ideas over now 1.9 million EMR patient encounters, and really learning through many thousands of hours in engaging with doctors, we came to an important conclusion, which is it's best first to go right, not up, in the BJ Fogg behavior design model. And what we mean by that is rather to try and find motivators. It is a lot easier, and as per the model, to rather make it easy for behavior to take place versus trying to bring upon external motivators which aren't necessarily sustainable. And we really have focused on a number of areas. The first principle is that to make it easy, the EMR has to complement and ideally, in fact, enhance existing practice workflows. Not just the clinical workflows, but in fact the financial workflows and how that weaves with the patient journey through the practice from the point of an appointment being made to, in the end, any outstanding money is being paid by the patient. It has to beat the pen. We'll talk about that a bit later, but the pen is incredibly easy to use versus 35 mouse clicks. And we have looked at introducing screens that are dynamic, powered through machine learning to really reduce the complexity of using an EMR. And lastly, ultimately empower the healthcare professional by consolidating all the relevant information, patient information, at that moment of care with that patient. The results have been far more gratifying, we think. We are privileged that of our doctors using EMRs, the usage is over 88% of all patient encounters. So 88% of patient encounters on a daily basis are processed and are used with an EMR. And the real litmus test for us is that we are seeing referrals to colleagues based on the experience that doctor clients have had. I want to touch on these 4 dynamics of ability and ease quickly. The first one being enhancing existing practice workflows. There are many practice workflows under the hood of a practice. And the elements that affect these workflows are the following. Firstly, the origin of the encounter. Was this a scheduled appointment, a walk-in, or an emergency? That could affect the workflows. Is this a face-to-face patient encounter, or nowadays a virtual encounter? That too affects the workflows of a practice. Is this a practice that's transitioning from paper, or a practice that started from the ground up digitally? Of course, there is the process with the patient, the subjective objective assessment plan process. There are outgoing tasks or workflows that take place after assessing the patient. Prescribing of medicine, requesting tests, referring, sick notes, billing instructions, other follow-ups, patient follow-ups, etc. The type of billing can often affect the practice workflow. Is this a patient covered by a medical aid with specific rules, by scheme, plan, option, and maybe contract that you've signed up to? Or is this a cash practice, a cash patient? And lastly, there are ad hoc incoming tasks or workflows like test results arriving, patients calling in, and certain amounts of admin that a practice needs to do. And the EMR in the end needs to take these existing workflows, not break them, not work against them, but work with them and in fact enhance them. Another important consideration is, as I mentioned earlier, the pen is actually very effective for a doctor. And so if an EMR is to be sustainably adopted, it needs to beat the pen. And the pen has got a number of factors. Again, is this a practice that has now a combination of old paper notes and now new digital notes? Does the doctor, in replacing the pen, prefer sliders with fingers tapping on the screen, standard templates? Does the doctor prefer typing or stylus? Again, while taking down these digital notes, they are different. If it's face-to-face or virtual, the environment is different. And that yellow folder is not only just to keep all the notes in, but typically it's got some very important summary information in the inside, like maybe some previous results, some high-level notes, allergies, and so on and so forth. And again, of course, you've got all the outgoing tasks that the pen is very good at. And ultimately, it's about usability, the speed of use, and being able to do so while maintaining that patient connection. And so the different configurations that meet the doctor where the doctor is at under these different modes of replacing the pen, possibly together with a virtual consult taking at the same place, is an important dimension of ensuring that an EMR is easy for a doctor to use. The next point is the complexity that a doctor needs to face, and really an EMR should ideally reduce that, not increase that. And the first concept is the coding complexity. For a GP, there are on average 200 procedures that could be performed. There are 67,000 NAPI codes or medicines to choose from, and there are about 40,000 ICD codes. Per claim, on average, there's 2.5 procedure lines, 3 medicines to be dispensed or prescribed, and 1.2 ICD-10 codes. And so that number you see there is the mathematical equation of all the permutations, which equates to about 1 million times more grains of sand on the planet of this earth. And this all needs to be landed while sitting with the patient. And so a good EMR will reduce this complexity as the patient proceeds through the patient consult. There's dosage complex. complexity, the drug strength, the form, the quantity, is it repeats, so on and so forth. And of course the formulary complexity around diagnosis, based on the diagnosis, based on the patient, the scheme, the plan, or the option that the patient belongs to, what drugs can or should be dispensed. And so once again, this is an opportunity and a requirement. We feel that an EMR needs to aid the doctor in reducing the complex, in some cases aided by machine learning to really reduce this complexity. And lastly, the ability to consolidate all patient information. Once again, there are many forms or sources of information, not just the clinical notes. There are external sources of information. And so things like providing pathology results, any other results, radiology tests, and so on, that allow the healthcare professional to be empowered to make the best decision possible is very important for an EMR. And in the end, what is wanted is sustainable adoption. And as I said, ultimately, doctors saying, I recommend this. Comments like capturing clinical notes are as easy as paper. I'm now more able to have, in fact, more eye contact with patients, as less handwriting is needed. And the fact that now I can do quick note capturing and with easy access to patient details, allergies, etc., is good sign for us that adoption is starting to set in. The journey is not complete. There is much still to be done for EMRs to continue to make more sense for doctors. And so the work needs to continue, we feel, by all health tech digital players to increase the ability and ease. No doubt a little bit of motivation will help, because that certainly moves that area up as well once an ability of ease has been arrived. And this really falls in the realms of contracts with schemes and administrators to share some of that patient data through an EMR that is asymmetrical and within patient confidentiality and within the bounds of POPI, for example, for potentially some alternative reimbursement. That can certainly help on the motivational level, providing that the ease is sufficient. And that's the important dimension that I want to bring up. And of course, given where we are today, which is the 13th of May, as I'm preparing this presentation for you, in a week's time, I think there's a very good chance that we will be having discussions about how Wave 3 is really kicking in. And once again, some of those extrinsic motivators will come through, which is how do I, over this process, continue to care for patients, who knows how big or how small the third wave will be. And importantly, for the business of my practice, how do I mitigate revenue loss? And once again, EMRs, over this COVID period, well integrated into a telehealth solution, certainly offers an opportunity to inoculate some of these threats ultimately that could be coming our way. So that's all from me. I hope this behavior design model is not only informative for you with relates to where you stand in terms of adopting an EMR, but also at a broader note for your patients and how to motivate them and get them to comply to the treatment protocols that you give them. Thank you very much for this opportunity. I hope you continue to have a good CPC Quali Care conference.